Thank you very much. We're going to, thank you, Director Kent. We're going to move on to item number 4, flat versus tiered structure. Felix Su, Senior Field and Policy Analyst, Health and Human Services Legislative Analyst Office. Good afternoon, and thank you for being here.
Absolutely, Mr. Chair. Thank you as well for having us. 1 second here while I get my bearings. So as the agenda notes, we've been asked today to present on 2 approaches to structuring an MCO tax. One is a so-called tiered approach, like the one proposed by the governor in January, while the other is a purely flat tax that would be assessed at a single rate on all MCO enrollment. Now, we were asked not just to describe these approaches, but to also highlight their key differences and their comparative advantages and drawbacks. So in our remarks, it's important to note that we're not here to endorse one approach versus the other. Instead, our goal is to lay out the distinctions between the 2 options so that it might help inform your decision process in crafting a funding solution during the special session. Also, our aim is to not just assert to you that these differences exist, but to explain why they exist so you can come away with an understanding of these trade-offs which are relevant and are important in any sort of proposal being considered. So we'll be presenting from the handout that's going around right now. It's a pretty hefty handout, and there's a lot more material than we have time to cover. But we hope that the document actually serves as a useful reference for you after the hearing. And our goal was to really put together something that could be a reliable resource as you continue to do this important and complex work. So, on to the presentation. On page 1, as we said, we have a lot of ground to cover. We'll start briefly with a refresher on the proposals, but really sort of highlighting the key characteristics that give rise to why they're so different in certain respects. Then, when it comes to thinking about what's important in terms of criteria for evaluating and judging one proposal versus the other, we'll be drawing upon some pretty standard concepts from public finance. One, how reliable or stable the tax structure is, both in terms of how easily the state can administer it, as well as obviously how much revenue it raises over the long term. And 2, the size of the tax burden, as well as who bears that tax. And we know there's a lot of interest in that. It's what we refer to sometimes as tax incidence. So by the end of the presentation, we'll have gone through a lot of material, and it may be difficult to keep track of. So we'll summarize everything in one table that will encapsulate the pros and cons that we'll have outlined for each approach. Now again, the point of this recap is not for us to land firmly on one approach being better or worse than the other. It's just to summarize in one place their comparative strengths and weaknesses so that later on you can go back and review those comparisons side by side and simultaneously, which hopefully will help your deliberations going forward. So skipping ahead to page 3 of the handout, we think there's pretty good understanding already in terms of what each proposal would entail. Director Kent did a good job of describing how the tiered structure would work, and a flat tax is pretty self-explanatory. Now, the key to understanding how and why they differ is to actually first recognize what features they have in common. It turns out that they do share key characteristics, but where they differ is in the degree to which these characteristics manifest themselves in economic terms. So our commonalities begin with, first, under both a tiered or a flat tax, according to the administration, the state would be able to continue to effectively reimburse the plans for the Medi-Cal portion of their tax. Now, we haven't verified independently whether this is really in compliance with federal guidelines, but assuming that this payback, if you will, is allowable, then it's also very important to recognize that this payback or this reimbursement is actually the vehicle through which we draw down federal funds. I want to spend a little bit of time on this because there's a lot of confusion about this. It's not as though, as is commonly thought, that we first collect the tax and then use the proceeds to draw down federal funds. It actually works in the opposite direction. We prospectively bill the cost of the tax into the managed care rates. And because that's a managed care Medi-Cal payment, it's eligible for federal match. That's the source of the federal funding, whether it's a broad tax, whether it's a tiered tax or a flat tax. Now, what I just described to you wouldn't work for the commercial tax or the tax paid on commercial coverage because that's not a Medi-Cal payment. Therefore, for that tax liability, there is no reimbursement to plans, there is no federal funds being drawn down, and effectively it's just a net payout from the MCOs to the state. That brings us to our last point, which is that in real economic terms, you want to think about both approaches as being a direct tax on commercial coverage only. Now, as some of you have pointed out, although the MCOs would be legally obligated to pay these taxes, over the long run, or even the medium term, it's likely that some part of this tax burden would be passed on to purchasers of coverage, including businesses and the state through CalPERS, through higher premiums. Now, if these approaches are so similar, where do they actually differ? As we said, it's a matter of degrees. Both approaches draw down federal funds, but they differ widely in terms of their capacity to do so. And both approaches would increase the cost of commercial coverage, but who bears that commercial cost and how big that total cost is on the industry varies widely as to a tiered versus a flat tax. And this has implications for how stable the approach is going forward, which is the subject of our next page. Now, as Ms. Wilson highlighted in her overview of the California managed care market, that market is undergoing some major changes, which will determine both how many plans are left operating in the state, as well as how large those plans are in terms of their membership. Now, as noted, there have been some high-profile mergers that are pending nationwide with implications in California. But even on top of what's occurring already, a tiered tax, by its very nature, has the potential to further alter the market landscape for MCOs. So take an example. If you have two different health plans competing for the same enrollment in the same regional market for commercial coverage, but one plan, by virtue of being a fairly large plan, faces an average tax rate of about a couple dollars per member month. Contrast that to its competitor, which may be a mid-sized plan, and therefore face a PMPM tax assessment that's as high as $20 per member per month. This would all add up to create a much higher cost of doing business for the mid-sized plan. Now you can see where this is headed. The mid-sized plan would lose out significantly in enrollment compared to the large plan. And overall in the industry, you could see some plans shrinking or even exiting the market altogether, and other plans growing or expanding in their absence. Now all this matters a great deal for the tiered tax structure because the tiers themselves, as you know, are delicately balanced on this assumption of how enrollment distribution is laid out in California. But the ironic thing is that these tiers also have the potential to alter this distribution and upset that balance. And when we talk about balance, we mean things like the federal permissibility question, which is the subject of page 5. So, as you know, the whole reason why we're talking about this today is our need to bring our MCO tax structure into federal compliance. A tax whose federal permissibility is an open and ongoing question is arguably the most unstable tax of all. Because if that tax is eventually found to be impermissible, it can no longer be implemented. And you could go from raising $1 billion plus in revenue in 1 year to zero in the next. So the administration in January built its proposal to satisfy these federal requirements and rules using DMHC enrollment data from the third quarter of 2014. We are now, at this point, approaching 1 year after that data point. Things have certainly changed in the marketplace, obviously with pending mergers, but also just with the natural course of enrollment shifts within the industry. Now, as we also mentioned, the tiered tax has the potential to further induce changes in both market and enrollment outcomes. If all these changes build up to a point where the enrollment shifts are material, you could face a almost house of cards situation where you're constantly building and rebuilding your tax tiers to remain in federal compliance as the enrollment landscape continues to evolve. Now, as we've highlighted in previous hearings, this could create an annual ritual in which every year the MCO tax collection is indefinitely held up as the state goes through the motions of revising the tax tiers, resubmitting them to the federal government, and waiting for reapproval. This can make things very complicated from both a budgetary and an administrative standpoint. Contrast that with a flat tax. Simple, clean, basically one tier, and by definition would automatically satisfy the default federal requirement for a uniform tax structure. Basically, you could set it and forget it. There would be no need to go back and reapply for a waiver or approval or anything like that. Now on page 6, by the same token, even if the state were able to manage to keep the tax tiers within federal compliance on an ongoing basis, these tax tiers, by design, the revenue that they raise depends on which plans belong to which tiers. Now, if plan enrollment goes up or down, that means they could shift between tiers over time. This could create a scenario in which revenue comes in far below than projected. For example, think of what happens if you have one already very large plan acquiring or buying a medium-sized plan. You would see all of a sudden the medium-sized plan's lives being assessed at a tax rate of about 75 cents per member month as opposed to $25 per member month. Again, a flat tax is immune to these types of issues. You have one tax, one rate, doesn't matter how big or small the plans are, doesn't matter who's merging with whom, as long as the total MCO enrollment across the industry remains stable, the revenue will remain stable. So far, the flat tax, looks to be pretty far ahead of the tier tax in terms of stability. So it'll be interesting to compare how they stack up in terms of the tax burden. Now, as we talk about on page 7 of the handout, the best way in our view to compare these approaches from a tax burden standpoint is to actually assign an identical funding target to each approach, and then work your way backwards to see how achieving that funding target would be different under the two options. Now, for our presentation today, we've chosen the $1.36 billion that the governor outlined in his budget. Again, that's $1.1 billion to maintain or to backfill the general fund offset for Medi-Cal, and $226 million for the IHSS restoration. Now, we recognize that there are other proposals to raise more revenue or to fund other purposes, but for the time being, just bear with us for this example with the $1.36 billion. So the governor's proposal in generating this amount would create a net liability of $670 million on the entire MCO industry. And again, when we say net, we're accounting for the paybacks that the plans can receive for the Medi-Cal portion of the tax. The liability for the 3 largest MCOs in the state would be around $265 million, or less than half of the total industry cost. Now, we highlight the 3 largest MCOs because they provide the bulk of health coverage for state workers and retirees. And again, when those plans' costs go up, then the cost for the state will eventually go up through higher premiums. Now, a flat tax and generating the same amount of $1.36 billion, we estimate would create a net liability of $950 million for the entire industry. What's more, the 3 largest MCOs would now bear 80% or more of that burden, something in the ballpark of $800 million in annual costs. So to understand what's going on here, let's start with a tier tax on page 8 of the handout. Now, I know the picture we have here is a familiar one to you from some of our past presentations, but we think it's helpful in showing how Medi-Cal versus non-medical plans are arrayed in terms of the enrollment distribution. It really provides a visual explanation to why the governor proposed tax tiers in the first place. Basically, the point is to impose the highest gross burden on mid-sized plans that tend to, but do not always, do a lot of Medi-Cal. And again, in the process, draw down federal funds through the matching for that reimbursement for the payback of those costs. Now, the mathematics is really pretty simple on page 9. The more you can reimburse plans for the Medi-Cal tax, and the more forgiving you can make a tax tier for the largest plans as a whole, the more you're able to reduce the net impact on the industry, and the more federal funds you can leverage for the state's use. But as you know, there are some mid-sized plans that don't do a lot of Medi-Cal, but they would still face the highest tax tiers due to their enrollment size. They would have no recourse for being directly reimbursed for their commercial liability. So these types of mid-sized plans are really the unluckiest losers under the governor's proposals. Combine that with the very large plans that have the lowest average tax rates, and you're basically creating that market scenario that we talked about at the beginning, where you can eventually affect the stability of the tax downstream. Now, before launching into how a flat tax compares on tax burden, on page 10, we lay out what you might consider to be the fundamental arithmetic of how any MCO tax proposal would have to work. Basically, it's very simple. For any given funding target, in our case, we're talking about $1.36 billion, that funding target has to be the sum of the federal funds that the Medi-Cal reimbursement draws down, plus whatever commercial tax liability the plans owe. And again, they cannot be reimbursed for that tax on the commercial side, therefore it's really their net liability. So I know this equation we have here might not be readily apparent to you, and in the interest of time, we're going to have to sort of make this an LAO trust us moment. But really, I mean, we work out an example here with the governor's proposal. You can see that the math balances out, that really this sum of $690 million being raised in federal funds in the governor's proposal nets out to $670 million in net liability to make up the whole $1.36 billion target. Now, on page 11, the reason why we're going through this whole exercise is to really make the following point. If you're structuring any sort of MCO tax approach to reach a given funding target, if you know that the federal funds that your approach will leverage are going to be less than others, then it's a corollary that the amount of commercial liability the industry has to bear will go up. So apply that reasoning to a flat tax. A flat tax is flat, therefore it's gentler, so to speak, on the mid-sized plans, but as a result, it also doesn't raise as much tax revenue from the Medi-Cal enrollment because Medi-Cal enrollees tend to be in mid-sized plans. This means that the state is only able to reimburse these plans at a lower level for the Medi-Cal liability and therefore draw down less federal funds. This then means, according to our equation, that the amount of net liability borne by the plans has to go up under a flat tax. And in this case, it would go up to the tune of nearly $300 million for the entire industry. Now, in terms of how this larger impact from a flat tax would be distributed across the different types of plans, on page 12, we point out that for very large MCOs, it's the flip side of what happens with mid-sized MCOs. The same uniform flat tax that would reduce the average tax rate for mid-sized MCOs would cause the average tax rate for large MCOs to go up significantly. So at the request of staff, on page 12, we provided our back-of-the-envelope calculations as to how each of these approaches would affect the 3 largest health plans in the state, as well as a couple of those mid-sized MCOs that don't do any Medi-Cal. So as you scan this table, we encourage you really not to fixate on any particular number, because again, these are really sort of rough ballpark estimates on our part, nor should you try to figure out, who plan A, B, or C is. That's not as important for the story of the entire table, which is that to flatten the tax structure from what the governor has proposed, you mitigate the impact on these mid-sized plans, but at a great expense to the largest plans in the state relatively. So finally, on our last page, to wrap up, as promised, we have a table here summarizing everything that we just went over. Now, as you look through this, we want to be clear that we didn't intend to have any specific ranking in terms of how we order these criteria. It's not as if the most important criteria are on the top of the table or the reverse, nor is the raw number of criteria on which one approach wins out over the other necessarily that important. As we've stressed all along, it really comes down to your choices and priorities in structuring a funding solution. Do you place more value on the short-term ability to maximize federal funds and to minimize the industry-wide impact? Or do you prioritize more long-term stability as a revenue source and the ease of the state in administering this tax vehicle? As a legislature, these are your choices in evaluating your options, and these are the factors that can sort of help you make that decision. For the time being, maybe the most important message conveyed by this table is that really looking through it, there's no clear slam dunk in terms of which proposal might be preferred by you versus the other. But we do hope that we've convinced you that these trade-offs are relevant and they're important. And going forward, we look forward to working with you and your staff to highlight any of these to the extent that they can help you make your final decisions. Thank you, and I can take any questions.
Thank you. Any questions from any of the members? I think Senator Pan was first, and then Senator Morlock. Is that correct?
Well, thank you so much for your presentation, and I think I certainly see the advantages on a short-term basis of trying to do the tiers, but I am concerned when we start talking about systematic impacts, when we talk about, so-called unintended market consequences, right? So, in the short term, as you said, if we do the tiers, we essentially, there's probably less burden. Most people are on larger plans, et cetera, so supposedly, but each, and we're talking about industry-wide impact, and certainly that's one way to look at it, but each plan or each company actually stands on its own and competes against all the others. And so we are creating a situation where essentially, I think, in the long run, or even not so long run, you're going to drive out of business, essentially, the mid-sized plans, because how are they going to compete with such a large when someone picks a plan, just that tax difference between what they might have to pay in one plan and another, and actually I find it's telling, I know you said don't look at any individual plan, but on page 12, I noticed that one MCO under the tier tax would actually, the mid-sized one, which is smaller, would actually have to pay a larger tier tax than a large MCO, right? I mean, so they clearly have a smaller number of people, of beneficiaries. But I mean, the fact is that, and I said again, not to pick particularly, but I mean, just the fact that a mid-sized plan would actually have a larger net liability than, with no Medi-Cal enrollment, than a large MCO. I don't see how they could compete, right? A large, who has more beneficiaries spread that out. So I mean, I imagine that plan isn't going to last for very long. I mean, they'll either get bought out or closed down or something. They're going away. They're not going to, I mean, I don't know how you survive in that kind of competitive disadvantage. So you're going to create a situation where basically only large plans will exist eventually. You're not going to have small plans will have to become mid-sized plans to become large plans. So there's no one else who's going to be added to the market unless someone comes in from outside, right? And then also, I guess it goes back to the question I did ask the director too, is when you drive out all the mid-sized plans, are the feds going to come back and say, because the only people left in the mid-sized plans are essentially Medi-Cal plans, and they come back and say it's no longer a broad-based tax, because essentially the only people left in the middle are Medi-Cal plans, and they're going to say, well, you got to redo your thing again. And I'm going to go back to saying, well, you need to either do a flat tier or something like that. And I realize that's, again, sort of trying to read the mind of CMS. But can you perhaps talk about maybe looking at it from a more dynamic basis, in the sense of we're sort of taking a slice of time now and saying, well, this is the impact, but let's just roll it out 3 years, and mid-sized plans go away. Then what happens, right? Mid-sized commercial plans essentially disappear. I mean, how does that then impact things over in the long run? And then also less competitiveness, therefore, in the market. You don't have them. Some of them participate in Covered California. They're gone. They won't exist anymore, et cetera. So how that impact when you have fewer players in the commercial market as well, especially in terms of premium competition for people buying in the commercial market.
Yes, so there's a lot of very good questions and important points there that you've sort of highlighted. And the one point that I think can't be emphasized enough is that the tier tax structure proposed by the administration was exactly done in a situation that you just highlighted. It was done based off of a static point-in-time snapshot of data from DMHC, which is at this point nearly a year old. And obviously, we're talking about using a freeze frame analysis to try to model not just the tax revenues, but also anticipate the ancillary market impacts in what is a very dynamic environment. Now, as to prognosticating as to whether you would really see plans driven out of business as a result of facing a high disparity in their tax liability, that's obviously hard to really confirm or deny that would happen. We just don't know.
You can't. I mean, you can look at markets and say, well, how does the behavior of people change when you have differences in premiums, right? And you know that at least the difference in premium, there'll be a certain difference in premium that'll be incorporated simply because of the difference in tax liability, because they just have, that's an expense that has to be borne, right? Because given that, and we've certainly seen, when we talk about debt spirals and so forth, now that's because of adverse selection differences, right? So what happens when you have adverse selection that drives premium differences? What happens to healthy people who then leave more expensive plans to go to cheaper plans, concentrating more of the sick, and then causing premiums to go up? In this case, you're going to have a differential created by a different tax structure. And then how does that then affect the behavior of healthy people, which then concentrates sick people? And are we going to, essentially, are we tipping over again, this is a model where we're going to tip over a situation where basically it's going to be very difficult for these plans to survive because the way people, I mean, the elasticity of demand for a plan by healthy people is something that I think has been analyzed previously looking at health plans.
Yes, and and part of our prepared remarks, we talked about the issue of a tiered tax creating. Basically, what we're pointing out is that two plans could face different costs of doing business, essentially, for no other reason other than the fact that we have an MCO tiered tax structure in place. Now, from the consumer perspective or the purchaser perspective, the question is that gap noticeable or material enough for them to make a decision or choice that they otherwise wouldn't have made? And this goes back, I think, to some of Senator Leno's important questions. Do we think a $15 added cost to a premium per member per month is really noticeable in the context of the types of percentage year-over-year differences that Ms. Wilson highlighted in her presentation? So I think it's all a matter of not just the fact that there is a raw difference in that tax rate that's being borne by the plans, but whether, in practical terms, that has meaning from an economic standpoint.
Okay, I believe Senator Morlock, question?
Thank you, Mr. Chair. Mr. Sue, I have just two quick questions. The first is, has the LAO ever prepared a report, and maybe I should have asked this offline, but where somewhere along the way, we decided the government should be involved in the healthcare industry, and there's got to be a trend of what that has been doing to our annual budgets. Is there a comparison year by year of how California addressing healthcare, how that's impacted our budgets? And if you have that kind of publication, I'd love to get the history of that.
Sure, we can certainly check back to see whether there's anything that meets your needs. And obviously, we have done quite a bit of work on healthcare policy and healthcare programs in the state budget in general. But just to make sure I understand the requests correctly, you're asking, is there an analysis of, what happened once state government got more involved with healthcare programs and delivery and financing? And
in the beginning, and then it evolved.
Medi-Cal dates back to 1965, right, obviously, and that's our biggest program, and that would be quite a far look back.
If there's something, it could be in a book or something. Yeah. Even if it's a book that you could refer me to.
We'll see if there's something that can at least partially get you there in terms of the information.
And the second question is, going off of Senator Pan's questions, can we do a blend? Why are we penalizing certain size MCOs? Why doesn't the state say backfill? And we do a 50-50 partnership of some sort so that we get the federal match, but we also have an effort where we, as a state, assist, so we're not treating anyone any differently or no better, no worse. At the end of the day, it is sort of like a flat tax.
So when you say blend, you're referring to adopting a MCO tax structure in part, but to also supplement that with other.
No, we're good about giving credits and rebates here. You almost wonder if you're paying the higher rates, the $20 rates, well, why not have that qualify for a tax credit that we reimburse? So at the end of the day, we're all paying a flat rate, but you've been able to achieve the higher federal match.
Sure, I think there's a lot of possibilities. Now, when you talk about those types of tax expenditures and credits that you could offer as to sort of make an MCO tax go down easier with the industry, there would obviously be some offsetting effect because those tax expenditures, by definition, cost money to the state budget. So, but yeah, we haven't analyzed that option in depth, but
no, you've given us,
possible.
An analysis of two options, and I'm just curious, Mr. Chair, if we could throw a third or a fourth, we can think outside the box a little bit. That's it. Thank you, Mr. Chair.
Well,
Thank you, Mr.
to get your vote, we're willing to have any discussion. No response, right?
Well, I don't want to get into it yet, but I do want to at least, probe and ask and explore some other alternatives other than just A and B.
Good. Senator Anderson.
When you were looking at your analysis between the two structures, did you take in consideration any kind of migration? So are you anticipating under perhaps the tiered approach, some of those companies that are being most punished shifting over to the Department of Insurance?
We didn't take that consideration formally in our analysis. In our discussions with stakeholders like health plans that would be paying this tax, the possibility has been, or the risk, I suppose you would sort of frame it, has been brought up. They also highlighted, though, that would require a whole process that, is sort of easier said than done, sort of getting licensed under a different department, sort of changing your product line to make sure that it conforms to the regulatory scheme of DOI versus DMHC. But, the one thing to keep in mind is that the full-service health plan model of insurance in terms of health coverage is really the dominant form today in California, and it would be hard to imagine a very large wholesale migration to, indemnity-type products or PPO as regulated by CDI.